acute kidney injury, as we all know, there is an increasing incidence of acute kidney injury, especially in pediatric, especially in pediatric sick patients. Luckily, pediatricians also are increasingly aware about this condition. We know that acute kidney injury, if present along with the multi-organ dysfunction, that will definitely add to the morbidity as well as mortality. The awareness and suspicion and prompt intervention can reduce the morbidity and mortality. To highlight on this topic, we have an excellent speaker, Susan Madam. Madam, over to you.
Thank you. Good morning, respected chairpersons, teachers, friends and colleagues. Let me first of all thank the organizers for giving me this august opportunity to be in front of you today morning to talk on a very important topic, that is acute kidney injury in children to complete renal shutdown. So in the next 20 minutes or so, we will be dealing with what is the importance, what is the epidemiology of AKI, and can we prevent AKI, can we diagnose AKI early, and whether early intervention make a change in the outcome, and what will we do if kidneys fail completely, and what are the recent developments. So an 8-year-old girl is referred from a rural area to the emergency department in a drowsy state. She gave history of polyuria, polydipsia, and marked weight loss over 2 weeks. She had dry mucous membrane, sunken eyes, and poor capillary refill, cold extremities. She was tachycardic and tachypneic with a low blood pressure on admission and had history of reduced urine output since that day morning. And her investigations revealed glucosuria, ketonuria, and urine microscopy was normal. The glucose was very high, urea was high, and creat was also high. And her ABG showed metabolic acidosis. She had hyponatremia also. So approaching this child, the problem-based approach, she has hypovolemia, hyperglycemia, hyponatremia, metabolic acidosis, ketosis, and azotemia. And as is obvious from whatever is the picture, you know that she is having diabetic ketoacidosis with acute kidney injury. So acute kidney injury is a new nomenclature. All of us know that as students we had learned acute renal failure. The terminology has changed. This syndrome is a sudden reversible decline in renal parenchymal function, resulting in accumulation of nitrogenous waste products, disturbance of water, electrolyte and acid-base balance, and blood pressure changes. And why the terminology has changed? When we were dealing with acute renal failure, we had a kidney that has completely failed. And so the diagnosis was delayed. And so delayed diagnosis will lead to delayed intervention, and the outcome was not good. And also, we could not compare because almost 30-35 definitions were there, and so studies were also difficult. So AKI is a new definition that has come. Early damage is recognized, definite criteria for staging, and early intervention is there, and we can also compare the mild to severe forms in their output. Previously, you know that we were picking up these patients when they were fluid overloaded, they were azotemic, and they were in a bad shape. So early diagnosis is critical in improving the outcome. So the evolution has happened over the years. We can see that this over the years, that is from 1950 to 2016, we are actually going forward in making a very, very early diagnosis from clinical, biochemical, going up to the cellular and even to the molecular levels. And in 2004, actually the rifle criteria came, and which was modified later by 2010, the ACIN criteria, that is the Acute Kidney Injury Network, and the KDIGO, that is Kidney Disease Improving Global Outcome. That definitions came. Still, that was not enough. We had to move further forward to the molecular, cellular and molecular levels in having the risk identified to make the early injury and to intervene early so that children will be better. And so the ADOCI, that is the Acute Disease Outcome Quality Initiative, the P-rifle criteria is for kids. We will be diagnosing children at risk, then in injury, failure, and then the outcome was also assessed as loss or ESKD. And then the KDIGO is actually the staging, that is stage 1, stage 2, and stage 3. The P-rifle criteria, looking at two things, that is one is the creatinine clearance, and second is the urine output. The creatinine clearance is calculated by the Schwartz formula. that is, all of us know the formula. It is 0.413 into height or length in centimeters divided by serum creatinine. That is looked at 8 hours, 16 hours and 24 hours, and you have to have the risk is then the creatinine clearance decreases by 25%, and the injury is creatinine clearance decreased by 50%, failure is when the creatinine clearance decreased by 75%, or the urine output criteria is less than 0.5 ml per kg per hour for 8 hours, or 16 hours 0.5 ml per kg per hour, or 24 hours 0.3 ml per kg per hour, or anuria for 12 hours is stage 3. So we can see that either the creatinine clearance or urine output, either one or the other is enough to make the diagnosis of AKI. And after 4 weeks, if the child is not recovering, you call it as persistent failure. And if the child has not recovered by 3 months, it is end stage, if the child is still on dialysis. KDIGO has modified this because calculating the creatinine clearance was becoming difficult. So, to look at the creatinine, considering creatinine alone, an increase of 0.3 milligram is stage 1, or 1.5 to 2 times the baseline, and increase 2 to 3 times is stage 2, and 3-fold increase or creatinine more than 4 is considered as stage 3 of AKI. AKI is common in children. We know that 5 to 10% of the hospitalized and 50 to 60% in the ICU. It is a significant contributor to morbidity and mortality, and up to 70% of acute kidney injury in the ICU is going to require dialysis, and it is an independent risk factor for death and new disability. Can we prevent AKI in the ICU as well as in the wards? Yes, we can do it by identifying the high-risk children and the high-risk procedures by judicious fluid therapy, that is the fluid resuscitation, timely inotrope support, pre-therapeutic and investigative precautions which have to be taken. For example, if you are giving a contrast, you have to be giving good hydration. You can give some drugs which can prevent the contrast nephropathy from occurring, especially in the setting of a compromised kidney or a compromised situation as patient in shock and all. And also we can avoid nephrotoxic medications and adequate care of the invasive lines and catheters. What I have seen is just the lines and catheters, if not taken care of properly, can act as a nidus for the infection to enter secondary infection and further damage, and can be the cause for AKI again. You will be escalating your antibiotics, giving more nephrotoxic agents and more hypotension, more multi-organ dysfunction when kidney is also a part of the culprit, as well as the part of the brunt of attack is also borne by the kidney, because the kidney has to be the housekeeping department of the body, and if the kidney is not working well, the whole of the organ systems are going to fail. So we have to be managing things in such a manner that we are preventing AKI. The second thing is, can we diagnose it? Serum creatinine is a late marker of AKI. Will anybody wait for 2 to 3 days before intervening in patients with acute MI or stroke? So we are having creatinine which will be increasing only once the GFR is declining more than 50%. So that is very late. So we have to have early markers. Do we have renal troponin set? So the biomarkers have come to help us in a big way, and there is a march of renal injury to the failure. There is increased risk, injury, damage, and once the GFR is reduced, the patient is going to have symptoms. And finally, in the acute renal failure phase, when the kidney has failed completely, most often things are diagnosed at this phase and we will not be able to act properly. So this is the current paradigm of AKI evaluation. First, clinical recognition occurs only when the GFR is reducing to the serum creatinine change is happening and the established injury is getting diagnosed. Can we do better? That is, first clinical recognition even before the glomerular filtration rate starts dropping, and the established injury is also detected very early, so that we can actually have we can prevent the ongoing injury, and we can also have the fluid management in a better manner and avoid complications. Which are the promising biomarkers that have come? That is kidney injury molecule 1, the neutrophil gelatinase associated lipocalin, interleukin 8, 18 and cystatin C. These are the promising biomarkers, and they have actually, studies have shown that especially in the cardiac surgery setting, the urinary NGAL done prior to surgery and at the time of surgery and immediately after surgery 2 hours, it is shown that children who are going to develop kidney injury are going to have a very high elevation of NGAL, and so we can actually intervene early in such cases. So if AKI is clinically suspected, then in the risk situation only you check the NGAL, the various values of NGAL is given, and if the NGAL is very high, you can see that there is a high risk of structural injury, more than 300 nanogram per ml, and all we have to, in the subsequent days when you see, you can see that the creat starts rising and the fluid overload becomes more. So you have to intervene early. The time tested old definitions of acute kidney injury and its causes, we know it can be pre-renal causes, intrinsic renal causes, or post-renal causes. And the intrinsic renal causes affecting the glomerular compartment, we have got the glomerular disease, inflammation, glomerulonephritis or thrombosis of the vessels. Then you have got the tubular indecision that is affected, that is ischemic tubular injury or toxic tubular injury. And then the interstitial nephritis and other vascular diseases are also important. And the most common cause of AKI in the situations that we come across clinically is acute tubular necrosis, and which can be ischemic most often in the ICU setting. And what is the phase of what are the different phases of ischemic ATN? We know that there is a pre-renal phase, and then there is an initiation phase, extension phase, maintenance phase, and recovery phase. It is going to take time for the recovery to come. Sometimes you may feel the output is come, but the creatinine is not improving. It may take 2 to 4 weeks for the kidney to recover. And ATN is associated with muddy brown granular cast in urine and also the tubular cell damage, and you can see that the renal biopsy, if we do, there will be sloughed tubular epithelial cells in the tubule. So how will we approach a pre-renal AKI? We have to take a good history, drug history and family history, do a good physical examination. Most important thing that you have to do, only 2 things I will say. You assess the volume status of the child and you palpate for the kidney and the bladder. So if the kidneys are palpable, the bladder is palpable, you know it is post-renal. And you relieve that and the AKI is resolved. If the volume is abnormal, volume is low, you have to give volume. And see, you have to give the fluid therapy, replacement fluid already it is discussed. And after you fill up the gap, that is the hypovolemia is corrected, you are expecting the urine to come. So in our child, she was resuscitated with IV fluid of 20 ml per kg, 2 boluses of saline, started on insulin, blood pressure improved to 100 by 70, urine output improved to 1 ml per kg per hour in the next 24 hours, and serum creatinine improved from 1.2 to 0.9, and urea came down to 44. So we are dealing with AKI rifle, or that is pre-renal AKI. Here it is only decreased renal perfusion without cellular injury, and the glomerular functions are intact, and if you correct the underlying cause, it is reversible at this point. And so timely fluid management is crucial in pre-renal AKI. And so fluid resuscitation, we give isotonic saline over 1 to 2 hours, output will increase to 1 ml per kg per hour. If there is no response to the first bolus, you can repeat the bolus, and if no response further, you give 1 furosemide, 1 to 2 milligram per kilogram per IV, up to 5 milligram per kg can be given, or you can give mannitol. Dopamine is indicated only in children who are in shock despite fluid resuscitation. Then one situation is indomethacin associated renal dysfunction. You can give dopamine plus furosemide in a preemie with RDS and oliguria. Unless proved otherwise, it is always better to treat as reversible renal failure when one is not sure. So in the prevention and treatment of ARF, if you consider, you can see that at the pre-renal phase, at the initiation phase, if you act, the recovery is going to be prompt. In the extension phase, even if you do whatever, and the maintenance phase also, the time is going to be taken, but better than in the natural course. So anytime you intervene, you are going to make a difference. A 9-year-old boy was brought to the casualty with 2 days history of fatigue, flu-like symptoms, generalized body ache, headache, nausea, and emesis. He was anuric for the last 24 hours. On examination, he was unresponsive with cold extremities. Skin was grey and mottled. He was tachycardic and hypotensive. And his counts were showing neutrophilia with leukocytosis and thrombocytopenia with severe metabolic acidosis and a deranged coagulation profile. His urea creat was again deranged and he was having borderline serum potassium. So what we can do, what are the possibilities? This child possibly is having a sepsis with shock, dengue fever with shock, or a meningococcemia because already the coagulation profile is so much deranged. Over the initial 12 hours, he was given 4.5 liters of fluid and the urine output in those 12 hours, it improved to 200 ml. But his coagulation worsened and he was developing bleeding and he receives 500 ml of FFP. Repeat serum creatinine is showing a rising trend and not declining as the first case. And over the next hours, we can see that even though the BP stabilized a bit, his creat rose to 3.2. Dopamine was started. He remains hypotensive and continuous infusion of epinephrine also started and he was intubated and ventilated. Blood culture grew Neisseria. Intermittent boluses of isotonic crystalline was given. His weight became from 40 kg, 46 kg. He was clinically edematous and total fluids in the next 24 hours was 3,250 and since admission it was 8.25 liters. Urine output in the same 24 hours was only 0.9 ml per kg per hour. And 0.9 ml per kg per hour, when you may see that the urine output is reasonable. But when you look at the fluid that is given and the output that is there, it is unreasonable. Now chest X-ray is becoming bad. Oxygenation was, in spite of being on ventilator, oxygenation was becoming more and more difficult. Critical care team is now requesting nephrology consultation. So this is the situation now. A single musician can play a melody, but it takes an orchestra to play a symphony. The same situation is there in the critical care medicine. We need a team to intervene. So this 9-year-old boy with sepsis, shock, fluid resuscitation, vasopressors, progressively rising creatinine, and the P-rifle criteria, he is in P-rifle F, that is failure, and he has possibly acute tubular necrosis. Worsening fluid overload, urine output seemingly adequate, that is 1.2 ml per kg per hour after all your interventions by giving diuretic and all. Flawed practice without assessing the net fluid balance is most often the cause of death in most of these children. So the concept of percentage fluid overload has to be taken in all the ICU settings. We have to have the percentage fluid overload calculated, that is total fluid in minus total fluid out, divided by the body weight into 100. You have to calculate daily, you have to assess how much fluid you are giving and calculate the fluid overload daily. You have to have a cumulative one. And fluid overload is going to be the killer. The fluid overload is going to have your lung getting affected and the oxygenation becoming difficult. Your heart is going to fail and the child is not going to come out. Fluid overload actually is AKI. So that is the concept now. If any child, when you are giving more fluids, is not able to bring out the urine and become fluid balanced, that child is actually having AKI. And dilution of serum creatinine occurs in fluid overload, and so your serum creatinine also may not be helping you because it may be erroneously low because of the fluid that has accumulated. It is diluted. So there is a concept called fluid adjusted creatinine. That is, you have to multiply the observed creatinine into the admission weight into 0.6, which will give you the total body water, plus the daily cumulative fluid balance, that is every day you add on, and divided by hospital admission weight into 0.6, which is going to give you the total fluid accumulation that has been there, and this multiplied by serum creatinine will give you the corrected serum creatinine. So that then you will see that the creatinine that you are seeing is maybe 0.8, but once you calculate this may become 1.2 or 1.4. And can we predict AKI in the acute illness? That is the renal angina index, which has come of late, a multidimensional real-time assessment of renal disease burden in the acute care setting. Admission to the ICU itself is moderate risk, and acute decompensated heart failure will put the child in high risk. Stem cell transplant recipient also is high risk. Very high risk is any child who is mechanically ventilated plus or minus inotrope support. So either inotrope support or mechanical ventilation put the child in very high risk. So the risk is the assessed and mark is given, and then signs of injury is assessed and mark is given. Signs of injury is assessed by assessing the estimated creatinine clearance decline and the fluid overload percentage. So let us see how we do it. So the score is given moderate risk is 1, high is 3, very high is 5. And creatinine clearance, no change, and fluid overload is less than 5%, the score is 1. 0 to 25% decline and fluid overload more than 5%, it is 2. 25 to 50 with fluid overload more than 10% is 4. And the estimated creatinine clearance decline by 50 more than 50% with fluid overload more than 15%, the score is 8. So you can see that a very high risk patient, for example, our child is having 18.2% fluid overload, GFR is declined more than 50%, very high risk, that is, he is mechanically ventilated and is on inotropes, his score is 40, that is the maximum score of renal angina index possible. So what to do if kidneys fail completely? Persistent oliguria, you will be giving lot of drugs, and many drugs have come like theophylline, dopamine, thyroxine, ATP magnesium chloride and all, given at this phase has not produced any impact in any of the studies. Maybe because already the bus is gone. Possibly we had to do these things at the point when the injury was starting or the patient was at risk or the whole process at the cellular level was starting. So the precious time is lost. We are at a point when the child is already in failure. And persistent oliguria, established renal failure, you will be going for, you will not be giving further diuretic. Now the kidney has failed. Now your thing is whether to go give conservative management of renal failure or whether to do dialysis. And so when we are going for conservative management, we have to have the fluid issues, that is a precise control of fluid balance, maintain the intravascular volume. We don't want hypovolemia. Hemodynamic stability is important.
Your time is
3 minutes more, no, man.
okay.
Insensible loss or ongoing losses you have to take. So we have to have euglycemia, isonatremia, pneumokalemia to be maintained. And AKI with hypovolemia, you give boluses of fluids. AKI with euvolemia, you give maintenance fluid. AKI with hypervolemia, restrict fluid or plan for fluid removal. Fluid accumulation more than 10% of the baseline is called fluid overload, and persistent use of furosemide will only lead to a delay in initiation of dialysis or ultrafiltration and even negative patient outcome. Early initiation of renal replacement therapy will improve the outcome. Hyperkalemia is a silent killer and we have to intervene, as all of us know. Drug dosing in AKI is important, the drugs to be adjusted based on the GFR. And what about the renal replacement therapy in AKI? It requires a lot of collaboration, coordination, early discussion and planning to execute the RRT. And the RRT, why we need to do dialysis? Because our kidney will remove the toxins, kidney will remove the potassium, the fluid, and replenish the bicarb. Once the kidney is gone, either you have to do peritoneal dialysis, hemodialysis or CRRT. And the general guideline is earlier the initiation, more benefit on the outcome. And we have to start RRT, that is renal replacement therapy, prior to the development of uremic symptoms. And fluid overload is an important factor which decides the timing of RRT. Creatinine is not, urea is not. Fluid overload is the leader now. We have to intervene if there is fluid overload. Indications of RRT, the fluid management, then always remember about the nutritional support. Nutrition is to be given properly, otherwise your outcome is going to be bad. So see, sometimes even to give nutrition, we may do dialysis to remove fluid. And for removing the components, we may, to create space in the vascular tree, we may do dialysis. Then intoxications, metabolite and electrolyte imbalance and all. And in the critical ill patient, 15% fluid overload or more is definitive indication. But if you need to provide large volumes of fluid as blood products, in a patient already more than 10% fluid overloaded also, you have to give dialysis. So acute dialysis modalities we know. The recent advances in pediatric dialysis, we are always constrained about the weight. And now the world is going ahead with the carpe diem, which is dialysis for babies between 2 to 9.9 kg. Aquedex for the newborn fluid removal, Newcastle infant dialysis and filtration system NIDUS. You can see how cute these machines look, which are for the babies. And so such things are happening around the world. And the new emerging therapies, these are all the currently undergoing trials are there. You can see that the iron chelators, then apoptosis inhibitors. People are making a lot of studies on animal models to find out the intervention early, whether it is going to make a benefit. 0 by 25 is a global initiative, that is by 2025 the AKI should not be the cause of death in the world. and especially this is an International Society of Nephrology guideline and initiative 0 by 25, which is for countries in Africa and Asia to do. It is an ambitious goal, globally applicable strategies for diagnosis, prevention and treatment of AKI. So let us conclude. AKI is common, often preventable and treatable. Early identification and treatment improves the outcome. Identify the at-risk people, monitor them appropriately, diagnose AKI early. Fluid overload is the real killer in critical illness. Judicious use of drugs, avoiding nephrotoxins, and timely renal support therapy to improve the outcome. Thank you.
Thank you very much for a very good presentation, Doctor. And of course, I think all of us have learned a lot of things from the talk. Only thing, it takes a little time, but I think you should have been given a little more time, because it is such an important topic for all of us. Because every time when we go to the ICU, we come across these problems, and we need a little more elaborate presentation. I think for 1 hour talk or something, sometime you can arrange. Thank you very much.
We say 20 ml per kg, 1 bolus, 2 bolus, like, is there any limit?
No, there is no limit as such. You give 20 ml per kg. You look at whether your baby's perfusions are improving, heart rate is falling. Is the child fluid responsive? If the child is fluid responsive, you can go on repeating your boluses. But now the dictum is, don't wait for inotrop to be started only after you have given all fluid boluses. Earlier we used to say give 60 ml per kg. If the child continues to be hypotensive, you start your inotrop. Now we say that you get a single line, you start your fluid bolus. You are getting a second line, you start the inotrop side by side. So you try to limit the boluses as much as possible, but there is no upper limit as such.
Because for a 30 kg child, like when you give 60 ml per kg, it's around 1,800. So do you need...
See, whenever you are talking about fluids, it is always the dry weight of the child. Just like means if you have a 10 kg child, 10-year-old child, then 30 kg itself you will be taking. If you have a 10-year-old child with 60 kgs, but the fluid will be to the 30 kg child. That would be better to give now.
Any other question from the audience? Okay. So we'll wind up the session. So I request Dr. Umla to present Dr. Shija Sugunan with a token of our appreciation. I request Dr. Rajesh I request Dr. Shija to present a memento to Dr. Rajesh. I request Dr. Susan Uthup to present Dr. Umla with a memento.